Chairman Silber, Director of the Infertility Center of St. Louis, and I'm here to answer any questions you have. Ask me any of the toughest questions you have and things that are bothering you most and you want to know about fertility.
Dr. Silber, what specific tests would you recommend to diagnose infertility?
Wow, so the question is, what are the tests that I recommend? Well, I recommend a minimum of tests. There are so many tests that couples often have to go through before they really get to treatment, and they can spend a fortune on tests that don't really help determine very much what you're going to do. Now, obviously, we have to know what the sperm count is, and that's an easy thing to do. And that's for the man. And obviously, for women, what do we do? What hormones do we get? Do we do laparoscopy? Well, I think that the most important single test is an ultrasound in which the ultrasonographer does a very accurate counting of the antral follicles. These small follicles that you see on ultrasound and often don't bother counting can be as few as 2 or 3 or as many as more than 40 or 60. And the antral follicle count is the most important single test I have, more important than any hormones for determining what your fertility level is, and in fact what our treatment would be.
Teresa would like to know if smoking, alcohol, or stress could affect fertility.
So what effect does smoking or alcohol or stress have on fertility? Well, you know, smoking is just terrible. We knew this in 1964, last century, from the Surgeon General's report. And in those days, so many people smoked. The cigarettes filled the patient waiting rooms in the hospitals. In fact, it was considered a patient's right in the hospital to smoke if they wanted to smoke, even though everybody else was damaged by secondhand smoke. I remember those days. But the Surgeon General's report demonstrated without any question that smoking will reduce the fertility rate, will increase the miscarriage rate, and has a terrible effect on the blood supply to the ovaries and on the quality of the eggs. So I am very, very successful in being brutally frank with all my patients. You must not have another single cigarette. And when they know their fertility depends on this, then we get them to quit because they cold turkey, and it's amazing because it's so hard to quit smoking. But if there's an immediate benefit to their fertility, people will stop, and you can't just gradually go off the cigarettes. You absolutely have to stop smoking completely. What about alcohol? Well, I wouldn't want to lie just to make you healthier, but aside from fetal alcohol syndrome and being a serious chronic alcoholic, having a glass of wine or two in the evening is not going to have a negative effect on your fertility. That's controversial, but we know that. The Europeans know that. We've studied that. Stress can have an enormous impact. But it won't have an impact on the quality of the eggs we get when we stimulate. It only has an effect on implantation at the time that we're actually doing the embryo transfer. So we really will work with you on meditation and muscle relaxation exercises, and it makes a big difference on uterine contractility and therefore embryo implantation rate.
Dr. Silber, is there anything you can do to improve the health of your sperm?
Okay, so the question is, what can be done to improve the sperm and the health of the sperm? There are all kinds of male fertility supplements out there that are all either ineffective or very dangerous. And it's really a fraudulent industry, frankly. There is really nothing you can do to improve the quality of the sperm because all those supplements, they contain some kind of steroid hormone, and they contain something that makes you feel like you're getting better, a bunch of vitamins which are harmless. But none of these things will improve the sperm. But you certainly can decrease the sperm count and the sperm quality by taking some of these supplements that have androgens or steroid hormones in them. So it's very important to avoid that. Furthermore, men are put on Clomid, men are given varicocelectomies. Men are even told to avoid hot baths and not to wear tight underwear. All these myths abound tremendously, but they really don't have any impact on the sperm count or the sperm quality. But the sperm count and the sperm quality fluctuate like this. So if you take a normal fertile man who's young and you just do a sperm count on him every month, and this has been done and reported in WHO reports, and it's in my book also, sperm counts go like this. So let's say you have a sperm count of 100 million per cc, which is good, and they give you Clomid. Next time you get a sperm count next week, it might be reduced to only 5 million. That dramatic a difference. Clomid obviously didn't cause the sperm count to go down. But what if your sperm count starts out very low and you go into the office and the doctor says, oh, your sperm count's low, it's only 5 million per cc. And any treatment he gives you, whether it's Clomid or whatever it is, seems to improve the sperm count because it might be 100 million next time you have it checked. But in truth, sperm counts fluctuate depending on sperm transport, sexual excitement, how long it takes to provide the specimen, but the daily sperm production rate goes unchanged. So you can be fooled into thinking any kind of worthless treatment is helping you, but it really doesn't. There's just a tremendous fluctuation in sperm count, and that is related to stress and emotions and really sperm transport with ejaculation.
We have a question from Jen. She would like to know, what are the benefits of transferring an embryo instead of a blastocyst?
Oh, okay. So that's a big controversy in IVF today. Do we do a day 3 transfer, so-called cleavage stage embryo, an 8-cell embryo, or do we culture them to day 5 or day 6 until they turn into blastocysts? So maybe some of the people out there don't know exactly what we mean, but if you're going through IVF, you do know this is a major controversy. So it's probably close to equivalent, but we studied 14,000 natural cycle cases of IVF, huge number, in which we looked at the live baby rate per egg, not per embryo, live baby rate per egg, depending on whether there was a day 3 cleavage stage transfer or a day 5 or 6 blastocyst transfer. And what we found is that there is a slightly improved live baby rate per egg with a day 3 transfer than a blastocyst transfer. Now, of course, a blastocyst transfer is going to give you a higher pregnancy rate per transfer. We know that. But we know that some day 3s don't make it to blastocysts in the incubator because the live baby rate per egg, and that's what is counting most important, live baby rate per egg, is higher with day 3 than blastocyst transfer. So our approach is, if we have a perfectly beautiful day 3 embryo, we'll either transfer it or freeze it. And any embryos that aren't perfectly beautiful, we'll culture on. And if they turn into blastocysts on day 5, 6, or 7, we'll freeze them and transfer them later in a normal cycle because they might be out of sync with your endometrium or your lining. So that way you have the best of both worlds. We know we're going to have the beautiful day 3 embryos with a very high pregnancy rate, but those that aren't so perfect, some of them are going to go to blastocysts, and then we'll be able to have those for a transfer later on.
Are your success rates higher with a fresh embryo transfer or a frozen embryo transfer?
Well, that's very interesting. Do we hurt the embryos at all by freezing them? And of course, in the old days, fresh transfer was dramatically better than frozen transfer. And you always had to wrestle in your mind, which embryos do we transfer, or do we transfer 3 or 4 embryos because we know fresh will be better than frozen. That was the way it used to be 2 decades ago. But since we introduced, and we were the first to introduce vitrification of embryos in 2003 from Japan. We were the first in the United States. And because we have a very close relationship with the Japanese clinic that first popularized vitrification. And at first there was a tremendous amount of negativism about vitrification. That is a very, very rapid freeze method, totally different from the machine-based slow freeze method. And it just seemed too simple. But it is so phenomenally successful. And so our success rate with fresh and frozen are absolutely the same. We will freeze with abandon, with no concern, if there's some other problem like a polyp or the endometrium is out of sync or just a sheer scheduling issue for the patient. We're happy to freeze all the embryos and save them for later because the success rate isn't down with frozens. Now, in many cases, the success rate is actually higher with frozen embryo transfer. In many cases, it's really, really higher. And why is that? That's because we can transfer the frozen embryo, thawing it, at exactly the right time in the endometrial cycle when the lining is perfectly suitable and hasn't been stressed by ovarian stimulation. So ironically, everybody would prefer a fresh transfer because they just want to get pregnant right away. But ironically, frozen embryo transfer is a little better than fresh, not worse.
Courtney would like to know, if I have had 2 placental abruptions, will having a biological baby be dangerous for me or the risk of new every time?
Well, I think that's an obstetric question you have to ask your obstetrician. But because abruptio placenta is a very, very dangerous occurrence. And if your obstetrician doesn't want you to get pregnant again, and we would go with that opinion, then it's no problem getting a gestational surrogate. We do more gestational surrogacy in the Midwest, I think, than anyone. We've been doing that since 1986 in cases of a poor uterus or an inoperable uterine problem or a health risk otherwise to the mother. And the pregnancy rate is extremely, extremely high with gestational surrogacy. And we don't think a uterine transplant like they talk about in Europe is appropriate in the United States because we really have no difficulty legally with a supply of women that are ready to carry babies. There's so many women that don't want to have more children. They've already had 2 or 3 or 4. They don't want to have more children, but they love being pregnant and carrying a baby and then giving it up. So we don't have a problem with that if that's the solution your obstetrician recommends.
Katie has a question. What are the positives and negatives of putting back 2 embryos instead of 1 with IVF?
Okay. Well, certainly the question is, do we put back 2 embryos or 1 embryo? The PC general principle is put back only 1 embryo and try for a singleton pregnancy. And so that's the common wisdom, and we're really happy to do it that way. But the data that shows the severe danger of twin pregnancy really comes from really huge trials in areas or in situations where really good, vigilant prenatal care and perinatal care is not available. Certainly with a twin pregnancy, you have a higher risk of early pregnancy loss, a higher risk of premature labor. There's no question about that. But the difference is really, really slight with really good obstetric care and good perinatology. And so in America, most women will prefer 2 embryos to be transferred. It will double the pregnancy rate per transfer. It will not increase the pregnancy rate per patient because when we freeze the embryos, we don't hurt them with modern vitrification. And so it's really a patient choice, and most women in the United States will prefer 2, but we're happy if they want 1, and we will never transfer more than 2 unless the woman is over 42 years old.
Dr. Silber, what do you recommend to help conception when you have adenomyosis?
Okay. Well, adenomyosis, you should first understand what that is. Many people may not understand it. It's technically endometriosis of the uterine muscle. And what that means is that endometrial lining, not just implanting in the peritoneal cavity or on the ovary, but endometrial lining islands diffusely infiltrating the muscle of the uterus. Now, if the adenomyosis is mild or small, we really don't pay any attention to it. You do the embryo transfer and women can get pregnant with mild adenomyosis. If they have severe adenomyosis, really big adenomyosis, and incapacitating menstrual pain, long menstrual periods, maybe 2 weeks, having to be in bed with pain, taking narcotics. I mean, this is a very, very severe condition, and usually a gynecologist will just recommend hysterectomy. But if a patient wants to keep her uterus and get pregnant again, we use an operation seldom done in the United States, but developed in Japan by Dr. Hisao Osada. And in fact, we have a video of that operation with us doing it with Dr. Osada on our website. It's a big operation. It's about a 3-hour operation, and we can actually carve out the adenomyotic tissue, which is very hard and miserable. It doesn't have a capsule like a myoma would have. So that's why doctors are generally afraid to operate on it other than hysterectomy. But we find it very successful. Dr. Osada developed it, and we can, with this open operation, small incision, and we inject with local anesthesia afterwards the last 2 or 3 days, so it's not very painful at all. And there's a dramatic improvement in symptoms, relief of menstrual pain and menstrual cramps and a normal menstrual period developing. But we like to wait 6 months after that procedure before doing an embryo transfer. So if it's bad adenomyosis, we have an operation for it, the Osada procedure. And if it's mild adenomyosis, frankly, I think it's best just to pay no attention to it.
We have a question from Jane. She says, my partner has a low sperm count. Can we still do IVF?
Well, as a matter of fact, a low sperm count is not a problem anymore. We developed the ICSI procedure even for men with no sperm in the ejaculate, having to retrieve sperm from the testicle. We developed that in 1993. So we have really 24 years of experience having pioneered, along with the Belgians, the ICSI procedure. And that just means intracytoplasmic sperm injection. What that means is with the tiniest number of sperm, we inject the sperm into the egg, and we get normal fertilization, normal pregnancy rates. And in fact, because it's so reliable, and we have such experience with it, we actually, in our IVF program, do ICSI on every single IVF cycle. We don't want to take any chance there's failed fertilization, and it's just faster and easier and more efficient, and we get a better fertilization rate just by doing ICSI for every IVF cycle. So don't worry about the low sperm count if you're doing IVF.
Dr. Silber, when was the Infertility Center of St. Louis established?
Well, I've been actually here doing infertility for 40 years. I think I'm the oldest living, longest practicing, still practicing infertility doctor in the world. And I started in 1976 here at St. Luke's Hospital. And originally it was microsurgery. We did the first microsurgical vasectomy reversals and vasoepididymostomies, and we did the first in the United States, not in the world, microsurgical tubal reversal at St. Luke's in 1978 or 9. And then we began doing IVF and gift procedures here in 1986, and we started the ICSI procedures in 1993. And combined them with sperm retrieval for azoospermia in 1994, and then did the first ovary transplants and frozen ovary transplants beginning in 1996. And so we've had a very, very long experience here. And so when you ask when was the Infertility Center of St. Louis established, it was really 40 years ago, but we didn't call it that until around 1986.
We have a question from Kimberly. Can I use my own eggs at age 42 for IVF?
So Kimberly wants to know, can she use her own eggs even though she's 42 years old for IVF? Well, the answer is certainly yes. Now, many centers will turn you down if you're over 40, and they won't do IVF, and they'll try to talk you into donor eggs. And I'm not against donor eggs. We have absolutely fantastic results, 31 years of following patients who had children from donor eggs, and I don't have any unhappy cases. I can explain that to you at a later point, but donor eggs are not a problem in my view. However, most women would like to get pregnant with their own eggs, And our approach of Clomid mini-ivf and storing up embryos and possibly multiple cycles of very minimal stimulation, we get pregnancies up to age 47. Now it's very, very tiny, remotely low pregnancy rate at 46 or 47, no question about it. But certainly at 42 and 43, pregnancy rate is very high if we can just store up enough quality embryos through minimal stimulation. So we would only recommend you go to donor eggs if we can't get anything good with mini-ivf. Now I should point out that the reason that no program or very few programs will use your own eggs at over 40 is because we have to report our IVF results to the government, to CDC. It's anonymous, but we have to do it, carefully regulated. So according to the law, that's not supposed to be used for marketing, but most IVF programs do use that for marketing because it's public. And so they would rather just do IUIs on you until you decide to use donor eggs, even though your pregnancy rate would be so much better with IVF, because they don't have to report IUI, and they can do hundreds of IUIs without having to report success rate. But we don't have that problem, and we're happy to take on older patients if we can get good quality embryos.
Do men stop making sperm when they're older?
That's interesting. The male menopause. Do men stop making sperm as they get older? No, they don't. It's amazing. The reason I know this for sure is we have over 12,000 men of various ages we've done vasectomy reversal on, older and younger, some of them as old as 75. And we don't find any problem with sperm production in older men. Now, it is true that if you look carefully on a population basis, men who are in their 80s have about a 10%, huge numbers, so the statistics mean something. Men in their 80s have about a 10% lower sperm count than men in their 40s. That was studied many, many years ago by andrologists. But that 10% difference in sperm count between men in their 80s and men in their 40s doesn't mean anything biologically. It had no effect on fertility. So no, I mean, men being older is not a problem. It's unfair. I could give you a beautiful explanation, a basic science explanation why. Whether you look at it as God made it this way or whether evolution made it this way, it doesn't matter. But why do women get infertile and their eggs get worse as they get older and it doesn't happen to men? I don't know if you want a detailed explanation, but it's fascinating from a basic science point of view that mutations occur in the testicle because of xeroxing errors as sperm are being produced. Mutations do not occur in the ovary because the egg does not undergo xeroxing changes. It's no stem cells. So in a way, the female of any mammalian species stabilizes the species against mutations, and the males, or the testicle, are responsible for mutational changes, which sometimes are beneficial and leads to evolution. So it's interesting biology.
We have our last question from Kimberly. Her husband is 52 and had a vasectomy over 20 years ago. Can they still use his sperm?
So the question is, since her husband is 52 and had a vasectomy over 20 years ago, can his sperm be used? Well, absolutely. We've, as I've said, had 12,000 cases over the last 40 years. And everybody gets mixed up about this. They will say incorrectly that sperm production is hurt in the testicle by the vasectomy because when they try to do a vasectomy reversal, they find no sperm in the vas fluid. Well, it's not because of any damage to the testicle or to the sperm. It's because there's a pressure buildup microscopically after vasectomy that causes perforations and blowouts in the more delicate ductwork closer to the testicle, which we call the epididymis. So they have blockage not only at their vasectomy site, but in the epididymis, which is close to the testicle. And in fact, we do vast epididymal repairs on these men 30 years after their vasectomy, and it's perfectly successful. But that sperm from these men who've had vasectomy a long time ago can be used for ICSI with complete success. So it's a myth, totally untrue, that having had a vasectomy for a long time has had any negative effect on the sperm. So where are we at?
One more question. What are the differences between IVF and mini-ivf, and how should someone pick between the two?
Okay, so the question is, what is the difference between regular IVF and mini-IVF, and how should one choose? How should one pick? Well, for sure, for older women with a smaller quantity of eggs, the mini-IVF is best because a massive increase in FSH just really hurts the quality of the eggs, and we've demonstrated that. It's been demonstrated in a lot of studies that the pregnancy rate per egg and the live baby rate per patient is inversely proportional to the total dosage of gonadotropin. So we think that minimal stimulation is always the best way to go. Now, whether you choose, say, Clomid for a minimal stimulation or a very low dose of FSH depends on the individual patient, and we can talk about that. But the basic principle is you want enough LH effect to give you a quality, and you want to get a minor amount of FSH effect to recruit eggs. But if you overdo it and over-recruit them, then you're getting a higher percentage of poor quality eggs. Now, we showed in these 14,000 cycles of just natural cycle, and I don't recommend natural cycle. It's very inconvenient, very difficult to do. But we get information from it that there's a 5 times live baby rate per egg when in an unstimulated cycle than in a stimulated cycle. It's like about 25 to 26% live baby rate per egg in a natural cycle, and in a stimulated cycle we know it's about 5 or 6% per egg. So it's a dramatic difference. So we recommend not overstimulating. Exactly how you do it depends on the individual patient, and we have to talk to you about it.
And that was our last question for the day.
Okay, I'm really happy to answer any other questions anytime. We'll do it again.